Then we are
Why two cycles? I mean, sir is doing bimanual. I mean, coaxial or bimanual. Sir is doing bimanual, I guess.
Bimanual.
Yeah, yeah.
Yeah, I have to meeting.
on the trip fluid I was washed and
Phenocane.
air bubble was replacing with viscoelastic.
Vivek sir, are we using any vitro reverse there?
I will try.
I think we will direct our question more.
Yeah, I'm waiting for phenocane. It's under topical.
Yeah.
It's not routinely that I use phenocane, but today I will be using.
I think the audience also will discuss few of the steps. What is my in the surgery? I generally use coaxial. I don't do two side put incision. I do one side put incision at 2.8 millimeter straight. So in this case, we can see the cortical cataract clearly over there, probably some component of like NS2 also. Yeah.
Good chance.
Use the Griffon blue dye and we generally wait for say 15-20 seconds for it to stay doing the CCT with the cystitome. Just wanted to for the residents and all that beginner surgeon, we are probably discussing few of the steps. Hello. Okay. Some of the surgeons do use CCC markers. So normally the marker is around 6 millimeter. So we are aiming for a 5 or a 5.2 millimeter CCC on the length. So when you mark 6 millimeter CCC on the corneal surface, it's going to be 5.2 at the lens surface because the lens being the shape of the lens being so much that the 5.2 will be the final result of that. Sir has done a nice Rexis. I think he has gone on almost completing the Rexis now. Rexis marker, there are two Rexis markers available in the market. 6.7 and 5.5. Yes, yes, yes. Maybe for premium ions.
Rexis of about 5 millimeter. 2.8.
Yeah. So for the beginners, probably doing a bigger Rexis is better around with a 6 millimeter marker. 5.5 marker, we generally use it for premium ions, especially where you want a perfect centration and the perfect images in the end of the surgery. Something like a dry focus and head of lens, we want better to have a 5.5 millimeter marker.
Little smaller Rexis, but I will be able to manage. I may face some difficulty in aspirating the cortex, or maybe some difficulty in aspirating EP nucleus.
Okay. Okay.
All the visco was washed thoroughly before doing any hydro. Until we wash, there will be chances of positive pressure, intralenticular positive pressure. If you don't wash any viscoelastic.
You're using what visco here? The standard 2%.
Using sodium hyaluronate for the Rexis, and afterwards I will be using HPMC. Rest all surgeons will be using visco.
Oh, okay.
I don't want it to prolapse. And slide inside the bag.
I've done the hydro right now, and it is trying to rotate the nucleus to see that the hydro dissection is complete. Yeah, to some extent we can see that peripheral gold ring also at some of the points.
2.2 millimeter incision.
Okay. I think in audience also, if you have some queries after the end of the case, probably
Yeah,
we'll
yeah,
discuss.
after the
We will
case, I
keep
will
on
ask you.
evolving as we go through the live session. This is going to be the first live session we are having at Nanded. Have one more mic there? Yeah. Okay.
For parameters,
Uh,
So
again,
can we display for parameters?
we are usually taking grade 2, sculpt mode. Having
Here IOP is around 65, then torsional power 0 to 65, vacuum will be 125 fixed, and aspiration flow rate is 22.
So the mode right now is the sculpting
no,
mode there
it will
or
be
a
centered.
prefix mode. Hello.
It will be centered. Just tell me.
Yeah, so the centration is excellent. There is no, so we are able to see clearly.
Are you able to see?
is it clearly visible there?
I'm going to do stop and chop.
Is the centration okay now?
You can chop. Disconnect. This is divided into half. I'll put stop mode now. अरे जनरेटर किस साइड होता है? Stop mode. Mode.
Hello.
There
Hello,
was
sir. Audible there? Hello.
right.
Hello. Yeah, you're back on, sir. We had a slight power cut off at that point.
Yeah, now it
Yeah,
is okay.
so you have started doing sculpting. You have completed the groove also, I think.
Yeah, now I'm doing chopping.
Okay. Which stick you're using, sir? The Kelman stick?
I'm using two. I'm not using chopper
Okay.
because this is a little softer one. Grade 2. So I made 6 pieces now. I'll start aspirating. Fine.
Dr. Jimmy, can you share the parameters during current remote?
You have to speak loudly.
Please share the parameters for current remote.
Currently, sir is using 450 vacuum, 42 aspiration flow rate, and torsional power 20 to 60.
Can somebody show the power also? Is there a facility for that? I mean, along with the surgery? Is it possible screen in the screen?
Correct.
Like we are having one screen which is focused on the cataract surgery, which is going, and one on the Dr. Vivek sir. So probably, yeah, that can be focused on the parameters if possible.
So I'm almost done.
Okay, sir. Yeah, nicely. All the pieces are coming. The flow rate is actually very good, I guess. What is the flow rate currently?
Pardon?
No, I want to ask Dr. Jemima sir, what is the flow rate at present?
Flow rate is 42, sir.
Oh, okay.
So for this particular machine, we use 42. Otherwise, flow rate in old machine, I was using around 30, 28, 30 flow rate.
Okay.
So it depends upon the machine you are using.
Yes.
All right.
So the flow rate is going to decide how much faster you're going to do surgery in a way.
So,
Excellent surgery till now, sir.
are you able to see?
Yeah, sir. You're starting your bimanual cortical aspiration. Now we can see, sir. We're not able to see the parameters of the machine. In case somebody can, point out that, will be better. Yeah, each step.
Here it is not working, sir. Yeah, they will.
Okay.
If some problem, we'll rectify in the second case. Just let me.
Okay, that's okay. Yeah, yeah.
We could see only.
Coaxial probably,
I think
the
my
water can
port
be.
is little smaller. I use new blade now. This is Alcon blade. So my irrigation port is a little bit larger. I'll have to enter the side port incision now.
Okay.
Little bit side port.
The difference in coaxial and bimanual will be probably in coaxial we have to use lesser water height also because we are making only one side port. So the anterior chamber
But
stability
I
will
am
be
more comfort. I have the coaxial also, but I am more comfortable with the bimanual.
bimanual.
The
Yeah, yeah.
flexibility of going into the sub incision space. And my
So,
chamber
so
is
probably the water height will be slightly more, I guess, right now.
my side port was smaller than usual because of new blade. So
Okay.
I rectified it now.
Yeah, yeah. We've seen that with your
Yeah.
enlarged. Sir.
Almost very rare cortex, very small cortex is there. Lens gap.
You can see few of the subincisional.
Yeah, yeah. So this
cortex.
is the flexibility I'm getting with the bimanual.
Yes, yes, yes.
The advantage of the scientific way for the irrigation way.
So
You
your
are
voice.
with the only one port,
Yeah,
and the procedure becomes little faster.
yes, yes.
Sub-incisional cortex will be little difficult one. So I'm almost through.
Yeah.
I'm
You are
taking a
speaking right now, HPMC 2%.
काहीच करू नकोस तुम्ही काही करू नका असं सांगू नका तुम्ही काय केलं तू नाही काही करू नकोस कुठल्याला भरून देऊ नकोस.
So this is the newer Clarion lens of the with the
I'll
self
keep
system.
some visco inside. My assistant has already filled it, but I'm not very sure, so I'll just recheck it.
Yeah, so from that port we have to put the visco till the time it comes out through the mouth of the fat race, and we have to. It has a CO2 cylinder which causes it to automatically push the lens from the.
See the injector? Yeah.
Yes, yes, we can see the.
Remove this part now.
Yeah, yeah.
Yeah.
So after removing that, we have to press it so that lens is getting forward. You can see that probably.
It is an automated delivery.
Yes, yes.
Yeah, lens is
With
now
pressing
going
and
to
the
inject.
yeah,
I'll stop at the end.
yes, yes.
Now I'll stop.
Yes.
Yeah, here I'm stopping.
So the only drawback with this system is you have to use the lens in 1 or 1.5 minutes. So you have to keep a standby
Yeah,
lens.
I have a
If
very
you notice at this point there is some red or
1
something
minute
like
is
that,
enough.
your lens just
Yeah.
finished.
If it is eventful case, do not use this.
Yes, yes, sir. So excellent surgery till now, sir.
I usually place my lens under irrigation. So my assistant was giving me irrigation. But as this is an automated delivery,
Yes, yes.
using visco, I do not use visco at this stage in regular lenses. I just have to press. I just have to be here and press the lip. Yes. The lens is ready to go.
Going on nicely, sir. Yes. So it has a very controlled delivery because of the CO2 cylinder which is there inside.
I'll just manage it. I'll just rotate it. I agree. This is my
That's what
use.
the reverse S shape of the lens opening.
As
That
I
is what
use
we.
irrigation, I have the flexibility to rotate the lens also, the inside also. Yeah. Easily it gets rotated. I can flip it. Yeah, the lens is there inside. I just have to do IA wash. Usually I don't use visco, so at this stage I do not need IA wash. In this particular case, मला visco there.
Yes, so most of the time this do happen while editing the lens. The leading haptics sometimes try to
भोसले सर वाचप झालेत का? भोसले सरांना वाचप करा.
leading haptics sometimes it opens up on the wrong side. So what I do in such cases is you have to slightly rotate the injector clockwise. So if you rotate it clockwise, it's going to open properly. And obviously, if it opens on the wrong side, if it is a biconcave,
Recording on केले का बघ. Meeting recording on कर म्हणा.
it doesn't matter if you put it in the sideways also, but in cases of plano convex lenses, we have to make sure that we're putting it in the right direction.
वर आहे का हे काय? किती ऍस्पिरेशन आहे? कमी झालं ऍस्पिरेशन. नाही हे किती आहे? व्हॅक्युम किती आहे? 4.5 करा व्हॅक्युम.
Yeah, I think we can have some questions now because the last step of cortical, I mean, the visco removal will be there and probably will do hydration. So you do anterior polishing also in such cases?
Can somebody put please? So I'm doing and do little hydro. Before hydro, I would like to put some paracan. Yes. Yes, I'll put moxie at the end.
Hello, yeah. So in monofocal lenses, it's okay to keep some visco also. Inadvertently, if there's some visco in the AC also, that is okay. You don't want to keep any visco because it's going to create post-op spikes also, and to some extent, it's going to create some inflammation also. But especially in cases something like toric lenses and multifocal lenses, you have to make sure that you are washing the visco behind the lens also. So most of the cases we have to go lift the lens and wash it behind also because that visco is going to rotate the lens. So especially in toric cases, it's going to be slightly problematic. And sometimes you have myopic shift of the patients of multifocal lenses because of keeping the visco in the back to a capsular distension kind of a thing can happen in such cases.
So I'm through.
Recently, there is an article related to the visco entrapment behind the IOL, especially in the acrylic lenses. On the day one, surprising myopic refraction is there, especially it is happening with the acrylic. It has tendency to come and stick to the anterior lens capsule and visco, and with BSS it is entrapped behind the IOL, which is getting washed off in a period of a week or two. So there are surprises post acrylic myopic
So
surface.
excuse me, I am through with the case. Thank you, Nanded Ophthalmic Society. Thank you, Dr. Kalekar. Thank you, Dr. Anand Patil. Thank you all. I hope.
Congratulations, sir, on behalf of all these dignitaries. I think you have done an excellent case with the excellent end result. And you have managed the opening of the lens, the leading haptic also very nicely. I mean, with the pressure of the live surgeries, probably some would have tried to rotate it.
You are there at other end, so I am not feeling like a live. I am doing a live for surgery for first time. Thank you for giving the company.
Yes, sir. Excellent surgery.
At the other end, so I am a bit relaxed now. More relaxed.
Yes. Sir, now you have to engage, with the live commentary. Probably you'll explain us what will be the second case who is going to do it, and we'll try to take some questions from the audience also if they have some kind of queries or some want to ask some choices of preferences in doing a phaco surgery.
Hello.
Hello.
Hello. Hello. Hello.
Hello.
Hello.
Yes, sir. You are audible. Yes.
Now.
There will be a 2 minutes gap between the cases. Second case is being prepared.
Okay.
Anybody wants to ask any questions, they are free to ask.
Yeah, we have given one mic in the audience. If somebody has any questions or want to ask some preferences of their Phaco practice, they can probably.
Yeah, Vivek sir, with 2.2 blade that you have used,
Yeah.
still you have made a biplanar incision, I guess.
Sir, can you repeat it a little louder?
You have made biplanar incision with 2.2, right?
Yeah.
So do you feel any difference of having single planar incision with 2.2 and biplanar with 2.2?
The 2.2 and 2.8.
2.2 only, sir. Like single planar 2.2 will be better or?
See, you need a watertight incision at the end. Whatever way you do three planar, two planar, single planar. 2.2 incision is already a smaller one. Just at the end, if you have a watertight wound, you will have astigmatism of around 0.1 to 0.2 diopter. That's all. That is my routine SIA.
We do all the cases with 2.2, sir. I generally prefer 2.8 in all my cases because I feel the maneuverability and the callability of the pieces is better in 2.8. 2.2, obviously the chamber stability will be more, but I feel in some of the harder grade cases, the chances of wound burn and probably epithelial, I mean, the descendant detachment is also more. So you haven't faced any these kind of problems in 2.2?
I learned it the way doing 2.2 in all cases. I do my brown cataract also with the 2.2. I'm
Oh.
using 2.2 maybe around since last 9 years.
Okay,
So
okay.
nowadays I'm used to it. I don't have a stock of 2.8 blades also. So it's
Okay.
all the matter of practice. If you practice with 2.2, you will be able to do. Hardly any. And also the good machine will make some difference. That is also there.
Yes, yes, obviously. Yeah, with the pressure control system and all that. How much water height you keep, sir, generally? What is the starting pressure you generally use while doing the quad mode, especially?
If I use a bottle height, I will use around 90 millimeter. And if I'm using IOP control system, I make it to see that IOP is kept around 45 to 50.
Okay, okay. So generally, see, if the bottle height is
I
say,
am using a 45, 50. So Bhosle sir must be using little lesser because he's more experienced than me.
yeah. So,
But I feel 45 pressure is enough, means it's good enough to maintain the chamber stability, and you do not feel a softness while doing surgery.
yeah, sir, if
There are
somebody can.
we are using 20, 25 IOP also while doing cataract on this machine. But somehow I am comfortable with in the range of 40 to 50 IOP.
Yes. So, I mean, as a beginner, we generally try to keep the bottle height on a higher side because that is going to keep your AC stable and avoid the surge. And progress doing more and more figures, probably you want a lesser pressure because it's going to reduce the chances of optical perfusion pressure which is there. I mean, it will not compromise the optical perfusion pressure. So that is the advantage of the most of the Alcon machines. So can you just focus on the machine also to some extent? We want to see the parameters and the modes for the beginners to understand.
Yeah, we can do it. Machine or camera can. Mari, display इकडे करा. Display or camera. सरांना क्लोज. सर इकडनं गेला तर चालेल क्लोज करा. Which eye is this?
Yeah, so we can see all the parameters over here. So the IOP, which is 65 now, so probably the bottle height would be around say 90 in such cases. I mean, whatever is the bottle height, we have to divide it by 1.3. So that is going to say it is 52 is the bottle height. So the IOP will be 40 in such cases. We have to just reduce it by 1.3. And the best thing about this is we have I think patient eye position is there in this, so it will automatically adjust the bottle height as per there's a sensor, sir, right? Hello? So these are the various modes. The first one is a pre-Phaco mode to remove the anterior cortical band which is there. Then I think it's slightly blurred here. So, you can vary the various parameters also. Vacuum 450. Sir has kept it kind of a linear mode. You can see that. We can keep it in various modes also. And the last one is the flow rate. So the camera is not showing the machine parameters right now. Yeah. So we show one important factor in the right side of the corner of the display is the CDE, cumulative dissipated energy, which tells us the amount of energy used for Phaco, complete Phaco, including skull and quadrant report. So which is actually very less in case of this century. So indirectly we can relate with the corneal health and the amount of energy dissipated. Dr. Vishnu, you were talking about the wound burn during Phaco surgery. For beginners, I would like to tell the most common Phaco step where the wound burn happens is the skull, where we are using continuous energy with no pulse. So usually burn happen there only, which appears at the end of surgery. So beginners struggles during the formation of the globe that probably residents should understand. During the skull, one has to understand, one has to keep watch that Phaco tip is exactly in the center of the sleeve. If it is on one side, probably that time only a burn can happen. You can have word, Dr. Vishnu, regarding movement or residents. So, if you have a very high grade of cataract, probably while sculpting also you can use this pulse mode and the burst mode, which will try to avoid the flow, this thing, the movement one and all. This one, I think. Hello, Dr. Vivek sir, I'm audible to you. Hello.
Hello. Hello, is it
Yeah.
audible? Yes, I will give the brief details about the patient.
Yeah, can you be little louder, please?
Yeah, we are going to start the second case. It is a
Okay.
60-year-old male patient and with a systemic comorbidity like
Hello,
hypertension.
hello. We are not able to listen. Hello, can you be little bit louder, please?
Patient is a diabetic one. He has grade 2 cataract, is diabetic and hypertensive. IL power is 18. Sir,
And
it's
the
going
P by K2, sir?
temporal clear corneal incision. It's a half diopter astigmatism, 180 axis.
How much diopter, sir?
Half diopter,
diopter.
0.5
Okay.
diopter. So
Okay,
he'll be
okay.
using monofocal only, but he will go temporal to reduce the astigmatism.
Okay, okay.
We have two anesthetists in the OT, and there are two vitreoretinal surgeons there in the OT to manage if anything goes wrong. I welcome and I thank Dr. Santosh Padmawar on behalf of Nanded Ophthalmic Society. He is there as an anesthetist. He is rendering his services free of cost.
Okay, okay. So you have ensured that you will not ask for charges later on.
I want a loud applause for him.
Surely, surely. We are pleased to have Dr. Santosh, sir.
He is there in the OT. He's standby VR surgeon right now, and
Yes.
Vishal Kulkarni will join afterwards.
Okay, okay.
Thank you,
Yeah.
Dr. Chetan.
I think till the time we start with the second case, we can have some questions. If anybody want to ask, Dr. Anand sir, hello.
Hello.
Yeah, we're starting with second case. Till that time, I think we can ask some interaction with the audience also. If you want to ask some question to us also. I just wanted to ask Dr. Anand sir, you use coaxial or bimanual? What is your preference while doing Phaco? Bimanual. You use bimanual. Okay. What about you, sir? Karika sir, you use coaxial or bimanual? Okay. Otherwise, sir, you bimanual. I personally use coaxial. I feel coaxial is much faster comparatively. We'll have little bit of problem while doing the sub-incision, but the stability of the anterior chamber is much better with coaxial. That's what I feel. Bimanual also, especially in few of the cases where probably sub-incision we are not able to remove, we have to go and convert it to bimanual. Or yeah, so it's I think it's a preference of practice and whatever one person feels comfortable about it. I think we should go ahead with that. As a beginner, I would suggest always use bimanual. And once you get to use the coaxial, it's quite faster. And the visco wash is excellent with the coaxial one. You don't have any post-operative pressure spikes and kind of post-operative inflammation with bimanual, the coaxial. What do you use, Dr. Guru?
I usually use bimanual, not at all used to coaxial. Bimanual only. Another important thing we are talking about the sub-incisional cortex removal during coaxial. Another important modification is that in that people use vacuum from the side ports, irrigation with the coaxial port. So they are going behind the vacuum, connected to the single vacuum probe, irrigation with the coaxial probe. That is an interesting modification that we can do. So we don't have to make one more incision for that.
हा माईक ऑन झाला का माझा नको करू तू थोडं 2 मिनिटं ऑन झाला का नाही नाही ओके ओके त्यांचं कम्युनिकेशन एवढं क्लिअर नाही म्हटलं येत नाही ना येतो का विचारावर चल आला श्रेया आला का बोल लाईट ऑन पुढे
Hello, Dr. Vishnu sir.
Hello. Yeah.
Sir, your voice is not very clearly audible inside the OR. We are doing some setting changes. Can you just speak?
Yeah. You are audible right now. In fact, it's both ways. Sometimes we are not able to listen what surgeon is speaking also. It's kind of getting kind of break in between.
Okay, from the surgeon's mic.
Yeah. Probably because of the mask also. Who is speaking from the mask, probably they'll have to speak little louder. And the holding of the mic also, as Sujata ma'am suggested, probably we are not holding the mic properly. Now I am audible, I guess.
Okay. This is the another mic. After the trolley is set, I will tell sir to try it once from the surgeon's mic.
Yes, the sound is very excellent right now, and you are very clearly audible, right?
Okay, sir.
Is Dr. Vivek there in the OT? Hello.
थोडं लहान करायचं
Hello. Do we have Dr. Jemima or Dr. Vivek there in the OT?
हो तसं कर बसता नाही हाईट जास्त पुढे सर आता ही लोएस्ट आहे फ्लोवर पाहिजे खुर्चीवर पाहिजे थोडी पाय अडकतात खाली टूल द्या ना साधा. रिव्हॉल्विंग टूल द्या. पुढे सरतो. खूप माहित आहे मला केबल वर करा. अरे खाली गेला तो. गुडगा मोड.
Hello.
अजून
Hello. I'm audible in the OT. Hello.
Yes. Ata, it is better, sir, now.
Yeah. Can we have like
We are monitoring the patient. There were some
okay.
arrangements going on. So now we are free. You can speak now.
Yes, sir. The centration is little on the higher side right now, probably or
No,
on the right.
It
Yeah.
will be
So
done. Under
yes.
process.
Yes. So the lens again is monofocal. What lens, sir? Clarion again?
Yeah, it is a monofocal one. It's a Clarion.
Okay. Okay.
Today we are going to use one Panoptix, one Toric, and rest 3 are Clarion plane.
Okay.
Monofocal.
So we have total 5 cases lined up. 1 is done. 4 remaining. Yeah.
असं टिल्ट करायला इथे का हे ते नाही हे माहित आहे मला. हे जवळ दूर करायचं ना. हा टिल्ट थोडा तेवढं नाही पाहिजे. तर वरच राहू दे.
So really commendable to do live surgery in the on the OT. Obviously now you can see that both laser was having little problem of the eyepieces. He prefers the eyepieces downside. Somebody will have a different tilt of the view. So I mean we have to really applaud these people because they are doing live surgery in the someone else's OT with all the different OT parameters and the different machines. So can you little bit centration is not there. Hello.
लाईट कडे बघत राहायचं.
The temporary.
Give me a little bit time, just we are adjusting the parameters.
No, the centration is not perfect. I mean, we can you just shift it to the right side a little bit? I think.
Yeah, 1 second. Surgeon is adjusting.
वर
1
पाहिजे.
second.
खाली चालत.
Okay. Okay.
त्याच्या लाईट को देतो. त्याच्या लाईट को देतो. नीचे नीचे नीचे. हा बस करेक्ट. सलेंडर त्याच्या लाइट को देखने का. जैसे ही ड्रॉप गिर गया ना तो ऊपर नहीं गिरना. हाँ
Hello. We are ready with the second case. Yeah, the centration is perfect right now.
कपड़े. अपने को कपड़े.
What I generally I do is I put a betadine drop like 3 to 5 minutes before that. We should keep it a contact time of 3 minutes. I generally don't put betadine right just before the surgery because then we have to really thoroughly wash the conjunctival sac in these cases. Probably sir is doing just an additional measure to put a betadine drop again.
So, Dr. Vishnu, the important thing is the contact time of 2 to 3 minutes is essential. So if we don't have contact time of 2 to 3 minutes, whatever betadine we are putting is not going to help us in view of stability. So a few people do it like before blocking, if you are putting it on topical patient. Before on table only, they will put the drops of betadine so that they can have contact time of 2 to 3 minutes, which is actually essential.
Hello, I'm Dr. Ajit Hazari, and on behalf of everybody in the OT, we welcome Dr. Manisha. He's also with us today.
Yes, we welcome you all.
Pleasure to be here.
Okay. It is eyepiece, eyepiece. Eyepiece picture मला ते center ला नाही ना ते.
I think they are using nasal speaking of Dr. Vishnu because surgeon is sitting on temporally, but speaking is on that side. So do you do regularly, like if you are putting temporal incision, you use nasal speculum or temporal?
I prefer the speculum on the temporal side only. I don't have any nasal speculum with me at present. In the institute at the age Delhi, we used to use sometimes with a deeper set eyes and all that. But now we can easily manage with the temporal speculum also.
Can we start now?
Yeah. So this the grade of the cataract in this cases, we are probably not able to make out clearly how much is the grade. Looks grade 2 to 3 to me, but
Where is going to speak?
hello.
Oh, good morning.
Violent is there. Yeah.
आम्हा खालीच बघत राहतो. चालवायचं नाही.
While doing topical Phaco, nowadays we don't do eyelash preparation and all. Using probably antibiotic 2 to 3 days before is also sometimes not required. A proper contact time of 3 to 5 minutes of betadine is probably one of the safest one. And few people use intracameral antibiotics at the end of surgery. So I prefer personally intracameral antibiotic at the end of surgery in each case.
Communicate him, stop late. Huh? Let them watch. Hello, good morning everyone. I will take this opportunity to thank Nanded Ophthalmological Society, Maharashtra Ophthalmological Society and Alcon. Nanded Netra Tatnya Samastha. All members. I'll show little different technique that I will work through main port only rather than side port. Okay.
Is it audible there?
Yeah. Little low with the voice, but we are audible. I mean, you are audible from that side. Yeah. So I think the preference of sir is to do straight away biplanar or the triplanar incision. I guess clear corneal incision is time to make.
चालायचं नाही का एक थेंब पडला की लगेच चालू नका. हं? खाली बघा बघा खाली बघा खाली बघा हलू नका. नीचे देखो जैसे. Then a clear cornea with 2.2 millimeter lead. Now
Yeah. There is slight refocus of the yeah. Now it is there. So the centration is not there. If somebody can slightly arrange the centration would be. Hello, I'm audible in the OT. Hello.
Yes, sir, you're audible. Just
Yeah. We are not able to see the complete cornea in the. I mean, the centration is slightly on the upside, I guess. Generally, I don't use Blu-rays in all the cases, only in kind of mature cataracts, which I do a very severe brown and black cataracts probably. And some of the pediatric cases we try to use. But routinely, whenever we have a retroillumination glow, which is quite good, don't use Blu-rays in all the cases. And whenever I use the Blu-rays, I personally prefer some amount of air before putting the dye straight away, so as to avoid the endothelial touch there. What is your preference, doctor?
I don't put a bubble, I directly put the dye. I usually use dye matcher also. Few people comments on the endothelial toxicity of the drug, but it is not like that. Because in DMEC, like keratoplasts, where we soak the basement membrane in the trypanoside itself. So, yeah, so does not make much difference.
Don't know, cornea is very- but- So काय तिकडे ते cornea- हा? ते काय दिलं मला दिलं पण नाही. काय? ते नाव देत नाही.
Infection is good, sir, now.
I think sir is making two side boards and must be planning to use binomial only. He has done a 2.2 millimeter temporal incision. He's taken it on a steeper axis, so we can tackle that 0.5, 0.7 astigmatism which is there. Sometimes we have a 1.25 cylinder. So in that cases, what we can do is an add-on incision at a 0 degree also at the end of surgery we can do. So that's the reason in cylinders up to 1.25 we don't need kind of a toric lenses. So sir is doing Rexes, probably the size is bigger, around I would guess it's around 6.5 to 7. But he has done a nice Rexes.
बोलायला चान्स आहे का नाही?
Doing a proper circular Rexes of 5, 5.5, sometimes 4.8 is absolutely essential if you're doing a premium IOL practice, especially trifocal, multifocal, head off and kind of loading lenses. Using the hydrodissection now. So he has completely gone under the capsule and reached up to the equator, and then only he has started with the jet of the hydrodissection. See, putting some whisper now so as to avoid any failure.
सोड दिलं.
Hello. Yeah, Dr. Jamaica, hello.
Uh,
Yeah. So sir just put the 2% HPMC, or he has coated the endothelium with viscose right now.
Yes, sir, we just visco, injected visco to protect endothelium.
Hello, I'm not able to hear. Hello.
Hello, hydro dissection was done just now.
Hello. Yeah. We would have some commentary from Dr. Bhosle, sir. Over to Dr. Bhosle, sir. You can go ahead with the steps of the surgery, sir.
You permit, I will stop something. Okay. Two point four.
Hello, hello, Dr. Nirima. Hello.
Hello?
It's over to Dr. Bosle, sir. He can probably, explain the sets and have a.
Yeah.
We are not able to hear anything right now as such.
Let me talk, okay?
Okay, sir.
Only 5 minutes
Comfortable
time, sir is
little
about to talk. Yes.
थोड़ा नीचे देखते रहो ऐसे देखते रहना था ऊपर नहीं देखना
But there is a kind of a voice break or something like that. That's fine. Okay, sir. Okay.
whether rexis and incision was visible there in audience.
Yes, sir. Yes, sir.
Okay. Now I will enter with the irrigation on. And I will take out a loose part first. So that you can अलीकडे बघा काका अलीकडे साईडकडे माझ्याकडे वर वर बघा हा बघा. ऊपर देखते रहो. It is little soft so that I am unable to demonstrate direct drop. So I will be able to show you little modified chop. Then half a tray. I will rotate in 180 degree. And now I will impel little deeper. And now chop will work very nicely. Did you see to all? Take out one quadrant so that it will give me little more space. Quadrant remember.
I think we are having some lag. There are some frames are getting, the internet connection is not that good. So in between, we are seeing some steps.
Beauty of this machine is I am just Phaco aspirating without utilizing any power. अलीकडे बघा माझ्याकडे सलेंट करण्यावर अरे थोडा थोडा किती तू पडवत
Yeah, excellently. Just done the quadratic wall right now.
थोड़ा अरे इतना नहीं जोर से नहीं.
So now the practice is shifting more and more towards topical Phaco. I mean, in metros and most of the good centers will doing Phaco surgery. Invariably, it is going to be topical over a period of time.
इसको जो मतलब नको हे काय नको साधं साधं मी काय बोललो आपण परत Lovely. Very good.
Now the steps of cortical aspiration, the bimanual.
Huh? It is slow, I think.
So they are increasing vacuum, I guess. to some extent. You could see the parameters there, the height is around 16, the vacuum is reaching up to 350, I guess, and the flow rate is around.
बरं ठीक आहे. नाही नाही ठीक आहे. एकशे तेरा आहे का नाही घेत. 35 आता घ्यायला पाहिजे का नाही घेत म्हटलं. It's because of stickiness. Vivek Motiwar wanted to test me because patient is diabetic, hypertensive.
We have a senior most surgeon over here. And
Not moving at all. He was
there is only one complicated and difficult case. I had called Bhosle sir. He said, keep anything for me. So I had no choice.
So you chosen probably the most difficult case with the non-cooperative patient and diabetic hypertension. That's what most people is there, I guess.
But he has
But
managed
that's
well.
excellent surgery. I mean, with the patient eye moving here and there, you can see that he's having difficulty centration also, but he's doing very nicely. The experience speaks for itself here in these cases.
beauty of a bimanual IA is you can go from 2 ports and such a sticky cortex you can remove with bimanual. With coaxial it becomes little difficult, so I request Alcon people to do bimanual with your machine.
Yes, yes, yes. I think patient is little uncooperative. That's why the irrigation is also coming out with the whole time. Except for the slide here. But sir, it's nicely managing it. You can see that excellent cortical removal is done right now.
सर कितनी बार छुट्टी ऊपर उठा रहे हो?
Observing the cortical back which are there. Most of the surgeons don't prefer the anterior capsular polishing. I personally prefer the posterior capsule polishing so as to avoid the any inanimate cells which are there.
Right, whatever.
Let's go and get ready for the plantation of the lens, I guess. This 2.2 millimeter incision probably we face difficulty when we are using 3-piece lenses, something like Technis lenses or so, because the cartridge there is a B type of cartilage, monarch 2 kind of, and we need the incision to be around 3.2 in such cases. So probably we need have to extend to some extent in such cases. I think now just before putting the lens, he extended it to 2.8.
लोड केलं नाही का कसं आहे
So that's the reason I prefer 2.8 from the beginning, and I'm comfortable in 2.8 because the maneuverability, the chamber stability with the 2.8 sleeve, I feel it is much better. But I guess that is the preference of the surgeon.
त्याच्यात
So we're getting ready with the lens now, I guess.
करून दे सगळं मला डायरेक्ट
Yeah, looks like a Clarion lens again. So the injector system which is there, it's called as automata injector system with the CO2 cylinder. It has an excellent control delivery. Not used many, one or two only till now, but yeah, there is a difference. Otherwise, what we use with Alcon is a titanium kind of a injector mostly. Yeah, so let's put the lens nicely. The leading haptic in the bag, the trailing haptic still there. Trying to maneuver it. So since he is holding at the optic haptic junction and trying to place the trailing haptic inside the bag. Yeah. So it's nice in the bag right now.
क्यों झटके मार रहे थे क्या जैसे उंगली लगे तो सुनना नहीं ऐसा इतना
So this was the Clarion. So very nicely done. Uncooperative patient, diabetic hypertensive.
Yes, sir. We can see that sir has managed it excellently. The patient was moving.
Few settings, but he's handled it very nicely.
Yes, sir. Yes, sir. We must congratulate Dr. Bhosle, sir. Yeah, it's an excellent service. Sir.
Next case where
Excellent demonstration. Surgical demonstration, excellent. Hanuman.
हा सर भिडे सर आहात का
होय होय.
Good morning everyone. Dr. Bhide, Santosh Bhide, President of Maharashtra Ophthalmic Society. He is there on the line. Bhide sir, please speak something.
Yes, yes, we can.
Santosh Bhide sir,
Yeah.
please
Good morning.
give your message. Yeah.
Yeah, sure. Am I audible?
Yeah.
Yes, sir. You are audible in the both in the OT and the auditorium, sir. Yes.
Okay. Good morning, everybody. And in the beginning, I must congratulate my friend Dr. Hanuman Bhosle. As usual, he has done an excellent surgical demonstration of Phaco emulsification, stop and shop technique, very good control over all the instruments. And I would like to congratulate all the organization, all the organizers, especially Dr. Vivek Motewar for taking initiative. And I think this is for the first time you are doing live relay in Nanded,
Yes,
if I'm not wrong.
Yes.
Yeah, so excellent surgical demonstration and very good initiative by Ophthalmologist Association from Nanded. My best wishes to all of you and all the best. And I'm sure during the day, we are going to have a great scientific feast. And I'm sure everyone will have some take-home messages and which everybody will be able to implement in their day-to-day practice. thank you once again for taking this conference or CME under aegis of Maharashtra Ophthalmological Society. And we at Maharashtra Ophthalmological Society are always there for all the academic activities by all the districts. Thank you once again. And my
Thank
best
you,
wishes.
PD sir. Thank you very much for participating in this CME remotely. Actually, this is just a physical CME, but as he is the president, he has joined it through the Zoom link. So nice of you, sparing time on the Sunday. And thank you for giving us an opportunity to conduct the CME under Maharashtra Ophthalmic Society.
Thank you.
Thank you so much.
Thank you. Thank you. And all the best to all of you. Thank you.
Thank you, sir.
Thank you for good words.
Thank you, Hanuman. Good.
Relation and everything, I don't know.
Yeah, it's not the vibration right now. Okay, it's done. Next surgery. Dr. Bhosle, sir, can I ask questions to Dr. Bhosle, sir? Sir, Dr. Ved, sir, hello.
खाली बघा आता तुम्ही डोळे काय बंद करतात हरकत आहे. फक्त तुम्ही काय पासून तरी करता की नाही. सगळं रचन पण त्याचं नाव काय तुम्ही पट्टी वगैरे लावत नाही ना काही. चष्मा लावणार सर. काढू मग.
Hello. Hello, am I audible there? Hello. I generally don't use beta at the end of surgery. You'll cause a lot of thinking. My personal preference is using the intracameral moxifloxacin in such cases. I use moxigram or Vigamox from the bottle, and sometimes urines also. You can see all the parameters at the downside. Yes. Hello, Dr. Chetan. Hello.
Hello.
Yeah. Dr. Vivek sir is there, I guess. Yeah. So
Vishnu.
can we have the patient data for the third case, please? Yeah.
Thank you, Bhosle sir. Our next patient is for Toric. Dr. Ajit Hazari sir is going to do that case. He's going to mark now. So we have kept the patient in front of the camera.
CD सांगायचं.
I can see the perimetry also done in this case. Yeah, I mean, some. Is it? Am I correct or no? I just could see from the files there.
Okay, thank you. There were very Phaco energy used in this case. The CD is 10.62. That means the Phaco power was used very less.
Yes. So the dissipated energy of the Phaco at the end of the case, you can see that the CD. So it was 10. So is that anyways? Yeah. So sir has managed it very well with the less Phaco energy. Most of the Phaco energy we use it kind of sculpting the nucleus and then while doing the mode only. Rest of the and I don't think so. Most of the time sculpting may use the Ozil mode because the groove from the Ozil mode will be a little wider, so you don't have to use the kind of Ozil mode at that point of time. The torsional mode I'm speaking about. So next we have a toric case. So generally we prefer doing the toric cases only if the cylinder is say more than 1.25, preferably 2 and above cylinders. So most of the time, the toric lenses are customized toric lenses. The company provides generally 1+1 lenses in these cases, most of the time. So the amount of toricity, will, depending on the toricity, you have different types of, the pricing is also a little different if you have a say toricity of more than 6 diopters or so. The lens is a little costlier if you have a toricity of more than 6. We'll see what are the parameters in this case. Am I audible in the OT? Hello? I think they're just in a preparation mode and discussing. Panoptics वही use कर रहे हैं.
Yeah. Hello, I am Dr. Ajit Hazari from the OT. Am I audible?
Yes, sir. You're audible, little lower on the voice, but audible, sir.
Are you asking me to lower the volume or raise the volume?
You have to little raise the voice, sir, because
Raise.
from the mask we are not able to hear clearly. Probably, yeah.
Can you hear me now clearly?
Yes, quite a lot.
Okay, so I'm going to do the toric marking for this patient, pre-op marking.
Yes.
Now, the first thing we need to remember that the patient's eye level and your eye level should be
Mhm.
almost the same. You can't stand and make the patient sit on a chair and do the marking.
Yes.
Is everybody with me?
Yes, sir. Yes.
Yes, on the screen.
Yeah, we can see, sir. You.
Now, if you notice, the patient has already tilted his head and he's looking towards the camera.
Yes.
You have to tell the patient to look straight.
Straight.
Convert forward here.
What are the K1, K2 readings, sir, in this case, if you know?
We'll get to the readings later. Right now, if we can focus on the marking, that'll be great.
So can we have front view? We are having side view, so we are not able to see. Can we have front view of it? From the front? Better.
So we have already put paracane and betadine in the patient's eye. आता डोळे उघडे ठेवा आणि माझ्याकडे बघा. So this is freehand marking, and it's quite obvious that it's not in the horizontal. Okay, so to assist me, I'm using the Toricam app by Graham Barrett. So here I have to hold the phone horizontal, center it on the cornea. सरळ बघा. So I've taken a photograph.
Yeah, can you focus on the camera, please? The view of the camera is slightly blurred.
Yeah. Okay.
Yeah, able to make out, but not able to see clearly. It's slightly. Now I think it is better. Yeah.
We have multiple photographs where we see
Yes, sir.
that it may be decentered. So this one is a little better centered.
Yes.
The centering, now this is gone up.
Yeah.
This is gone oblique, and it's not centered on the cornea. So you have multiple photographs. You select the best one. Okay, so this is probably the best that is selected, and we are off by 2 degrees from the horizontal.
Yes. Sir.
So this is what is going to guide us for when we are implanting the IOL.
The final pose. Yeah.
This is off by 2 degrees. So
So
what
you,
when we assume that the blue marked at 100 are at 9 at the horizontal, we are off by 2 degrees. So we have to
yes,
alter our implantation accordingly by 2 degrees.
yes, sir.
Are you with me?
Yes, sir, yes, sir, yes, sir.
Great. Then we'll proceed with the case now.
Yeah, generally you use the marking with this, the pen only, sir, or you use junction violet or something like that?
Second time. Position till then.
Hello, is it audible now?
Yeah,
Hello?
audible. Yeah, it's audible now. Ajay sir, this is your preferred method of for toric marking, or do you use slit lamp marking or freehand? Which one is the preferred method for use?
Hello? Is it audible now?
Hello. Yeah, it's audible.
Sir, please speak loudly.
Okay, just wanted to ask Ajit sir, which is the preferred method for him for toric marking, like a freehand method or slit lamp marking or bubble marker sir is using?
So the simple answer is whatever you're comfortable with and
Okay.
whatever works best in your hand is the best way to go ahead with. For me, I started with the bubble marker
Right.
and then gradually progressed to the freehand along with the Barrett Toricam app. So present, this is what I follow whenever I'm doing manual marking.
Right, sir. In this particular case, we are talking about the deviation is around 2 degree. But if we see the marking, what we have made is like it is almost occupying 5 degrees. Like smudge is there, so it is almost occupying 5 degrees.
Yeah, so that's the advantage of using the Toricam app. So whatever is apparent, you need to validate with your equipment.
Right.
Yeah, I thought that I'm off at least 5 degrees. But
Sir, but in your own setup, you use it the kind of the slit lamp marking or the same way you do, sir, with the toric lamp?
so I use the freehand marking, and along with that, I use the Toricam
Toric.
app.
Okay, freehand and toric. Yeah. So, what Dr. Nikhil was speaking about the smudge you have is like if you have a kind of a tricornea, the marking will be very much, I would guess, precise. Yeah, crispy and with slight. I mean, sir is trying whatever is best in the OT with the patient blinking and all. It's going to be a moist surface with the. So that's the reason there is a smudge. But with an excellent Toricam and the app, probably he will account for all that smudge and the 2 degree of rotation which is already there. Yeah.
So when you're doing manual marking, there's going to be some amount of movement by the patient, some blinking.
Yes.
some
Yes.
tick.
Sir. Yes. Sir. Yes. Sir.
Even with the bubble marker, sometimes it becomes difficult. The marking gets smudged. Don't need to write. Don't need to. डोळे बंद ठेवा.
I will just give the pre-op details of the patient. He's a 75 years old male patient. Diabetic patient which is on control levels. He had unaided vision of 624 in the left eye, which is improving to 618, and NS2 grade of cataract. His K1, K2 values are on the flatter side. K1 is 39.75 and K2 is 40.25.
Axillary.
Can you repeat the K values, please?
39.75.
39.75 and the K2 is 41.
38.79 and 40.16 at once. And astigmatism of 1.37 at 170 degrees of axis.
Axillary is 4.9 and 5 miles.
Axial length is 24.83. No,
My side, I guess.
4.99.
One. Can we ask two questions to Dr. Hazari sir meanwhile in between? Hello.
Sure.
Yeah, sir, this patient seems little on a myopic side. If you have a patient with a very high myopia and you're using toric, especially with the axial length of say 27, 28 and all. So is there a difference while doing a surgery in the way that so as to make the proper centration, do we use CTR in some of these cases without any zonal dialysis? Still, you use CTR in such cases so as to make sure that we are having the proper centration.
Yeah, so basically this is a flat cornea, but high myope.
Yes, yes, yes.
What we are going to do is try not to inflate the chamber too much.
Yes.
So chamber doesn't become too deep.
Yeah, but in your private practice sir, with a high myope of say 27 and more axial lengths, you're using toric or for that matter, say panoptics or a multifocal. Trifocal. So do you use CTR in some of these cases? We had that standard of practice in AIMS sir, with a axial length of more than 27. We used to do CTR so as to make sure that the centration of these kind of lenses are good in the end.
So the beauty of the Alcon lenses is that even if the bag is very large, still the
Yeah.
So usually I don't need to use any CTR unless I feel that the lens is not centered properly.
Okay. Okay.
लग जाएगा, side लगेगा, camera तो है.
Just for audience sake purpose, I mean, whenever we have a very high myope with a 27 and more axial length, the bag is going to be quite big. And in such cases, if you try to keep a lens with a 6 or say 5.2 millimeter axis, it is going to go to the off center most of the time. So it is going to create some issues. That's the reason at our institute level, we used to put a CTR so as to make the bag size proper and then put the premium angles, so the centration will be better in such cases. Only cases with a high myopia of say more than 27 millimeter of eye length and so. So here there is a flatter cornea on the 39-40 side with the myopia in the axial length. Probably it is tackling all by itself. So don't need these kind of things in these cases.
Can we have a look at toric planner provided by Alcon? We haven't seen that yet. Toric planner we want to see.
ठीक है क्या हाइट ऑन कैसे करता है लाइट हाउ डू यू स्विच ऑन द लाइट माइक्रोस्कोप लाइट कैसे ऑन करता हाँ So here you can see that the cornea is completely dried up.
Yes, the sensation is good, sir. We can see that it is completely dried up. So we know that the astigmatism is around 1.25 in this case. Can somebody show us the toric planar printout, sir, in case if it is available? Yeah, we can see the toric planar printout. But it is not that clear, I guess.
It's not able to, it's not visible, sir. Details are not visible. It's okay, it's okay. Sir. Yeah, yeah. Okay.
After bringing the marker, toric marker. नहीं गोल तुमसे जमा देते हैं toric marker कितना होता है I'm just getting used to the microscope controls. समोर तुम्हाला दोन लाईट दिसत आहेत का बाबा लाईट कडे बघत राहायचं
Situation is excellent, sir. We are able to see complete corner.
Yeah. We're just waiting for the toric alignment ring so I can show where the 4 degrees is. So implantation actually is supposed to be at 4 degrees, but we are off by 2 degrees. So instead of 4 degrees, we have to implant the lens at 6 degrees.
Right. Right.
If that's understood, then we can proceed with the surgery.
Yeah.
So in a high myope, it's better to be precise with the size of your rectus, because in a high myope, you tend to make a slightly rectus. You cannot guide it.
sure.
अन्ना भी किधर गए क्या हमारे अन्ना भी किधर गए की फोटो
So go to the other one.
पता लगा ये तो चाचा खोले
That was a 2.2 millimeter incident. Sorry. This is. Go ahead. So I'm inflating the chamber with sodium hyaluronate.
इसका तो इसका तीसरा है ना हाँ तीसरा है
So we just got the ring marker here.
12 तक है साढ़े 12 के करीब में लगा
This was supposed to be the 180.
अभी दो लेता हूँ आधे घंटे की अभी दो लेता हूँ
There's the 26 number maybe, right?
क्या है ना हाँ था
Is the marking on the cornea visible for the rectus?
Yes, sir, it is visible.
बाद में मेरा
Think sir's preference is also with the cystic curve. Making the radial cut and using the triangle technique where you use the tangential force to do a good circular axis.
So the previous case, Dr. Motivar, I think, used the 1 millimeter side force. And it's making it difficult for the bimanuals to go in. We are using instead the 1.2, which would be slightly more comfortable for video eye. Hi, sir. Thank you. Here for hydrodissection, I'm using a flat tip cannula. It's a disposable cannula from Tricon. And works very well.
Yeah, the way went nicely, sir.
code. This code. Yes. This code. So I use multiple viscoelastics. I use HPMC on the cornea. I use sodium hyaluronic to do the red switch. And I use dispersive viscoelastic to coat the endothelium. Now, another precaution that we take in a high height is we'll also put some amount of the coat behind the iris.
I didn't get the last step, the voice got broken up, sir. Behind the iris, you said what, sir?
In the dispersive viscoelastic which coat
Yeah.
now, and
Oh.
I towards the endothelium and push. So it forms the endothelial coat. And at the same time, I'll go
Yeah.
behind the iris also and put in some of the viscoelastic there. So that when we take a probe, so when we enter with the Phaco probe, the iris and the lens doesn't get pushed behind. Okay. So we are in sculpt mode now with an IOP of 26.
Yes, we can see on the screen, sir. The parameters are also visible.
So that's great. Okay, so I don't need to comment about the parameters now.
In between, sir, whatever you see the difference. Yeah.
I'm purging some amount of the viscoelastic from the anterior chamber. Do you see this white cloud here? This white cloud at the tip of the Phaco probe
Yes, yes, sir. We
is
can.
actually the viscoelastic.
Yes, yes.
Because we put the dispersive viscoelastic, the tendency of the tip to block is high.
Yes.
First you aspirate some of that, and then you start.
So it's doing.
Right कडे बघा.
Yeah.
काय होतंय? हो माझा हात आहे तो. माझा हात ठेवलाय तो. काळजी करू नका. हा? काही झालं तर माझ्याशी बोला तुम्ही. हा हात वर नका. So this is slightly harder than what I'd anticipated.
Yeah, looks harder, sir. Yes.
We are going to the next setting of grade 3 cataract. Okay. So I use a standard blunt chopper. We are in chop mode now.
Sir.
Let's go back to Phaco 3.
So we can see that the first separation was quite good and complete, so that's the reason he's able to make the rest of the nucleus into small pieces. The grade of the candidate looks little harder, grade 2, 3 kind of a thing, yeah. So it was an excellent choice of sir to go ahead with the viscose also, so as to protect the endothelium in these cases.
डोकं हलवू नका हं. एकदम जर करताय तुम्ही असं करा. आता हात आहे तरी. घाबरू नका. थोडं वजन असलं तर सहन करा. दुखत नाही ना? दुखतंय का? तर तुम्ही असंच बघत राहा. So now we have according to full we made about eight pieces there. So mind you, this is a high myo, and you can see that it is not very deep. That the IOP is thin. Just considering the 30 or so.
Yes, sir, 26. I mean, excellent surgery with a very low IOP, sir, causing less compromise on the optical, the optic nerve of the exam.
मोतीबिंदू निघाला आहे, रिलॅक्स. ओके.
Yes.
थोडस साफ क्लीन करायचं, साफ करायचं आणि लेन्स बसवायचे. ठीक आहे ना? Always good to have a dialogue with the patient, I feel. Get to know what the patient's also going through.
Yes. Yes.
Right.
So the rest of the steps are going to be the same. Now the interesting part of implantation of Tori as is going to come. So do you do acid polish in such cases? Do you do anti-capsular polishing in such cases, sir, routinely?
Yeah, I've made the routine practice now.
Okay.
2.4, 2.4, Nagesh. Okay. So when I'm doing implantation under ISO, all the lenses going through 0.2, but hydro, I think that you need a slightly larger incision for the lens to go in. So this is 2.4. Because slight side cut on the inner end of the.
We are not able to hear actually. We couldn't hear the last two things, sir. The voice was keeping a lot. Yeah. I guess you little widen the main incision, sir, from 2.2 to 2.8, I guess.
2.4 I made because
2.4.
I was under hydro.
Okay.
This is side. You have enough resistance from the eyeball when you insert them. If you're putting it on the hydro, I find that the resistance is slightly larger incision helps.
Okay.
Then so the implantation is at 4 degrees. The protection of that parrot, sorry.
We can see the visuals clearly, but the voice is breaking, so the internet connection is not that great at the moment, I guess. Yeah, we can see that you are marking as 0 and 182 and the toric lens is going to have a marking at the optic haptic junction, and we have to make sure that we are aligning it properly with the corneal marking which we are. Yeah, so that's already coded, I guess.
अल्फांसो फोर्सेस किधर है इंजेक्टर के साथ रहेगा
So which lens you are using, sir? Here?
Is using Clarion, na? Toric.
using the toric lens.
Toric. Okay.
Yeah, can you see it on your screen?
Yes, sir. The power 21.5 and the cylinder at the IO level is 2.2, but yeah, we can see.
Yeah.
Yes, sir. Yes, sir.
Sorry, it's accuracy of toric.
Okay, yeah.
If you open the wagon wheel, this is how it looks.
So this is the accuracy of toric lens, accuracy of IQ based lens we can see. There is loading in the cartridge. So you will be using the metal injector like this, sir, in this case. Yeah, so it's nicely cut
Metal
the
injector.
trailing haptic.
The Monarch injector, which is a standard injector which we use with all IQs,
Yes, yes.
all accuracy of lenses. And the lens, the cartridge that we're using is the D cartridge, which is compatible with 2.2.
Yes. The standard Alcon Monarch injector system are using here.
थोडं प्रेशर जाणवेल हा तुम्हाला आता बघा बघत राहा हो हो कमी होऊन जातं ना. त्यामध्ये
Sinski is trying to the back. Yeah.
with the accuracy of lenses. If the OT temperature is very low, like what it is here at 80, exposed to that temperature, it becomes slightly stiffer and the unfolding is slightly slower.
Yeah, the memory of the language. Yes. Yeah, after the whisper washer, if possible, would like to go to a slightly bigger magnification. So the audience here can see the marking of the toric, the lens on itself, sir, if possible.
So I'm removing whatever residual visco was there in it.
Yeah, so it's nicely going under the lens. So this is one of the critical steps. I mean, we have to follow, especially if you're using the OVD, the dispersive one, the Discord one. So if you don't wash it properly, so there is going to be a post-operative rotation of the toric lens. It is going to create some cylinder in those cases. So sir, excellently washing both on the up surface of the lens and the under surface of the lens. He's doing a very thorough whisper wash.
Proper. Proper. Shall I?
We can see the bucket is excellently centered. We can see the inverted fourth bucket images also there. So that's the, yeah, so you can clearly see the bucket image back on the center, saying that the lens is properly centered. Probably after your hydration, we would like to go to a higher magnification and see the toric markings on the lens if possible.
So it was an excellent surgery. So needs applause.
Dr. Vivek sir, can we have a slightly magnified view of the lens? We want to show the toric markings
Pardon?
on the lens, sir. We
Pardon?
want to show the toric. Hello. We want
You
to
want
show
to
the
see?
toric markings on the
Toric
lens.
markings you are seeing.
for
You
this.
want to see.
Yeah,
Zoom it. Yeah.
yeah.
You want to see the alignment.
Yeah, sir. We are seeing some reflexes, sir. Not able to make out the toric marking on the lens, if possible.
Now,
Yeah, it is perfectly aligned. I hope they can see.
Yeah, we are seeing some glistening reflections, but it's not that.
Maybe sir, we can reduce some illumination so that we can see the markings. Or maybe return we can reduce.
and with
So is the retro on there? Retro element?
can you see it?
Reduce the illumination, sir, to some extent, because we're getting a lot of reflections from the lens surface, the anterior lens surface. Sir. Now it is getting clearer to some extent, I guess.
Yeah, now you can see it.
Okay, so the focus is not there on the lens at present time.
So here I don't, in case of the Alfonso, I don't undercorrect or overcorrect.
Okay, excellent surgery, sir. Thanks a lot. Yeah.
This is intracameral moxifloxacin.
Yeah, that is what I routinely do in all my cases. Intracameral moxie, I use every case.
Right.
Dr. Vivek, sir, do you use routinely intracameral moxie in all cases?
Nowadays I have started. Initially I was not using. Whenever I was doing
Nowadays, you are using. Yeah.
Can you listen me?
Yeah. We can, sir. Now we can listen.
Yeah, I started doing topical Phaco. I am using it, but still.
Okay. And what you prefer, sir, for intracameral?
Pardon?
What you prefer for intracameral? Which brand of moxie you use, sir, generally?
For pin, pre-filled syringe. This is from Nanded.
Acha, tomato. Okay.
Ready-made syringe.
Okay.
Like to use the eye drops as a intracameral one.
I use the Vigamox or a Moxigram from the Microvision. From last 5 years, I'm using it and I feel comfortable.
Successful and a nice demonstrating surgery.
So
It was
the
a
total
wonderful
is quite less, 8.38, I guess.
to demonstrate toric surgery live, and he was very bang on the axis. Congratulations, sir, and thank you.
Yeah.
Yeah. Congratulations, sir, for that.
So,
Yeah.
is ready.
We are having some applause from the audience also in a form of clapping. Thank you, sir, for explaining the steps also in detail and bearing with us.
Any questions?
Right, sir. This is Dr. Nikhil, sir. Just wanted to ask Ajit, sir, a few questions, a few queries from my side.
Pardon?
I couldn't hear that question.
Few queries from my side, sir. Right, on maintenance, toric ring, if we see, we don't have 2 degree, or we have count on 10 degrees only. So now before marking only, we have deviated 2 degrees.
Yeah, so instead of the intention of 4 degrees implantation, we we aligned it because our initial marking was off by 2 degrees.
Yeah, so 4 + 2, 6 degrees we have targeted. But on Mendes toric ring, we don't have 6 degrees to mark.
Exactly.
have 2 degrees
That's the
there.
disadvantage. That is the disadvantage of manual marking. If you have markerless toric system, then you have 1 degree on that system. Like I've been using Perion for last 4 years now. And this is practically after 4 years that I've done a manual marking today. So on the web one you can implant it exactly on the axis that you intend to. If you notice the specific marking which is there, that itself is 5 degrees. So the smudge which is there on the limbus, each smudge itself is about 3 to 5 degrees. So that much inaccuracy is inherent in manual marking and implantation. But the toric lens, as we will talk later in the day during my talk, the toric lens is an extremely forgiving lens. And 2 degrees, 4 degrees here or there, the patient is usually asymptomatic and most of the time 6/6. The other about this lens is that the stability is fantastic. Now you saw me that I rotated and I kept it and I kept tapping the lens and it didn't budge at all. Even when I inflated the anterior chamber at the end, it didn't budge. So when you're using a toric lens, make sure that the AC doesn't collapse once you put in the IOL because that will reduce the rotation of the IOL. And the other thing I'd like all the audience to notice was that the axial length of this patient was 24.99. So that's almost 25 millimeters per axial length. And with a normal cornea of, let's say, 42, 43 keratometries, you would expect to put a lens somewhere in the range of 13 or 14 diopters. But because of the keratometry was flat, it is a flat cornea, long axial length, we put in a lens of 21.5 diopters. Now, this practically was a surgery in a high myope with long axial length. But what I'd like you to notice is that there was no fluctuation of the anterior chamber except during irrigation aspiration because this is a different bimanual and we were using settings which are from my machine and my bimanual. But that glitch, everything went off very smoothly and the patient was not feeling any pain. He was just feeling the heaviness of my hands on his shoulder, on his forehead and his cheek. But otherwise, the patient was very comfortable. So,
Yes.
high myope under topical, patient comfort is a very significant factor. And here, IOP Phaco with a IOP of 26 to 30, which is equal to a bottle height of around 40, 45. Makes the patient extremely comfortable and the surgery is very smooth.
Yeah.
Thank you.
Any
other
Especially
question?
in high bias, maintaining the IOP is much important. And here comes the value of the Alcon machines and all that. Yes.
Right then. Thank you so much.
Sir, if you are placing the lens with visco instead of irrigation, do you prefer any decentration?
Yeah, so the question is if we are implanting the IOL under viscoelastic, do
Did
you
not get the question. We did not get the question. Sorry.
yeah, the question was if you implant the IOL under viscoelastic, do you expect any decentration?
Okay.
You should expect decentration if you have not removed the viscoelastic from behind the IOL. So especially when we are putting a toric IOL and for that matter any IOL, it is critical that you go behind the IOL and flush out all the visco, aspirate it out so that the adhesion between the capsule and the lens
is strong and there is minimal destabilization of the IOL.
Sir, in which cases you revisit these kind of cases with the post-op rotation? I mean, up to 5 to 8 degree, I would guess that would be manageable. Patient won't be that much symptomatic, they would be happy. But if you feel that the rotation is more than 10 degree, do you revisit and align them again?
So I've been using the Alcon toric for last ever since it was launched, somewhere around 2008. And it is my go-to lens. The straightforward reason being that it is extremely stable in the anterior chamber with no decentration. So even if there is a decentration of 2-3 degrees up to 5 degrees, as you said, the patient is asymptomatic for it and the vision is excellent. And this is more so in the small torics, like, up to 0.75 diopter or 1 diopter astigmatism. This lens works beautifully.
Oh, okay.
So one more question, ma'am. I just wanted to ask in small people, how do you see the toric marking over the IOL?
So with the
Like,
help of a
if you
dialer,
just raise
with the help of a dialer or a chopper, you just retract the iris a bit and see the marking. So it's
Okay.
usually no problem.
Right.
If it's an oblique implantation, it can be slightly challenging, like 40 degrees or so, in a small pupil, but usually in a 90 degrees or a 180 degrees axis, even in a small pupil, it's usually a simple, straightforward patient.
So one more interesting thing that I have noticed that you have put visco below the iris. Do you do this for routine in all cases or like high maps only in particular this case?
Only in high myopes, because you can expect there's a push to the iris lens diaphragm. It gets pushed behind because of the irrigation force. That becomes very, very less with IOP at 26 or 30. But if it's a high bottle height, somewhere like 100 or so, and then as soon as you enter the anterior chamber in a high myope, the AC side.
Like here is.
So I think that's a lot. It prevents pain to the patient, especially in topical.
Right.
Question, sir. If you are using visco behind the iris, do you anytime get a zonular disease just because of visco?
Never. I mean,
Okay, thank you, sir. Any more questions from the audience? We are ready with the next case. Next surgeon is Dr. Manish Shah, a renowned glaucoma specialist and a Phaco surgeon from Mumbai. He will be doing 2 cases. His first case is grade 2 cataract, and he will be using Clarion monofocal.
Any incision site preferences, sir? Any astigmatism? Even K2 values, sir, if you can.
I'll tell you.
Yes, please.
Is 42.45 and 42.87. 0.43 astigmatism on the axis. So he will be doing temporal surgery. His SIS is only 0.1. So unless he increases the incision, he will end up in astigmatism of 0.3.
Yes,
If he does 2.2 only.
Hello. Yes. Good morning, everybody. And it is a great pleasure to be in this lovely operation theater. Vivek has organized a beautiful place, and I am really happy to be here. So we have a grade 2 cataract here. I am just focusing the microscope. And though I am a lot into glaucoma, so everybody expected that I should demonstrate a combined surgery. Maybe sometime I would be happy to do that too. Dr. Bhosle is very keen. Sure, I will be very happy to do so. So this
Yes,
is,
sir is saying he will organize the CME next month or next year. He will organize the same CME at Parbani, and he wants to do a glaucoma surgery there.
I will.
And he will invite all of us there in Parbani, and he will treat us like he will give a red carpet welcome to us. That is what we also expect from Bhosle, sir.
So I will just go over a little bit of what I prefer to do. Everybody has their own, different things that we like to do. I use a 1 mm side port blade, and for the main incision, I use a 2.2 bi-bevel blade from Alcon. So this is my side port. And another thing which I have done is I never do any counter pressure. All my incisions are single-handed, which I have been criticized a lot from, but I am doing this for 25 years. I don't give counter pressure. Even with a blade which is not so sharp also, I can manage. So these are my side ports are made. I'm using Coevisc from Appa as my viscoelastic in the anterior chamber. Okay. Now this is my blade. So this is a dual bevel. This is a dual bevel Alcon 2.2 blade, which I love. So I have brought it from Bombay myself. So this is my main incision. And for some reason today it is blunt. It is not cutting the way I've seen it cutting. I don't know what has happened today, but anyway, I got my incision there. Now, this is again visco. Rexis forceps. I use a Rexis forceps, micro Rexis, and make a little incision first. Hold one end, and that's it. So it's a little smaller than I would like. It's okay. This is saline. Saline. I'm using the cannula which comes with the Coevisc, the 27 gauge cannula for hydrodissection. I don't use a chopper, I use a Sinski hook as my side port instrument. No, this is not a Sinski hook. ये open कर आणखी नसेल. QB quadrant. It's not going somewhere. It's a grade 2 cataract, so it's not needing much power. I don't use separate parameters for epinucleus. I just go with the same parameters and take out whatever comes out. And I go straight to IA. It's not going, I don't know. Foot switch is not cortex.
So most of us do that, and most of the time, if you have a good AC chamber, kind of
Air bubbles are a
no fluctuation, we straight away can go ahead with the nucleus removal, the same Phaco quad set also. So here in this step, as Dr. Hazari was mentioning, probably with a high myopia, the convalescence of the iris, the patient will feel a lot of pain if you're doing it in topical. Precisely, that is the reason I somehow feel coaxial is slightly better. Because the main port is open here, so the flow rate is going to be compromised because of that. The wound is going to leak to some extent. So sir is doing the cortical removal. This thing.
Yes, Clarion. Hydro. So after I do the cortex.
Yes, sir. Except step, very fast surgery, I would say.
Can I speak?
Sure, sir.
Yeah, so I like to polish the posterior capsule with hydro. That is, and I do anterior capsule polishing also as a routine, just like Ajit had shown. Only difference is I do it after I put the lens.
Hydro polishing is the best way and it is the safest way to do the polishing. And the results are very good.
So now I am going to show the Clarion lens and it comes like this. This is the stopper. So first you have to remove the stopper. Then you have to fill the viscoelastic. My technique of filling viscoelastic is little different from what Alcon teaches in their video. So I put a little over here and then I put from the other side. Because the way that Alcon shows no, in that there's too much of wastage. So I like to, I am a Bania after all. So I like to save where it is, where I can. So now interesting, usually the haptic inside the injector flexes. In this case, the haptic has not flexed. And I'm glad that has happened in the live surgery because that happens and you have to face the music. So it is not a problem. Let it happen. If we can handle it, because the lens is a very nice lens. This is the same 2.2 incision. I have not extended. I am doing a wound assist only. There just flex the lens a little bit and it goes in properly. There the lens is in. So this is with the autonomous injector. And that's it. लाइट के सामने देखिए नारायण जी हाँ बस ऐसे लेंस भी डाल दिया अभी आपका okay now I do the IA and along no don't keep cortex only same setting I don't change my setting same settings I do the polish also it is on your foot you can control everything with your foot so why do you need to keep changing settings. So my assistants are also quite happy. Now I am doing the anterior capsule polishing. And I'm happy that the lens is there so that I don't inadvertently. Sometimes if the bag is lax while you do polishing, you can land up with a little zonular damage. So you have to see what's happening. And use very low vacuum. So your foot sweat pedal does the trick. And if you can show, I am not seeing the screen, but if the person can show the screen, my foot pedal is controlling the vacuum and I can get a good polishing. So that's the end of the surgery. And I like to stroke the incisions like this before I hydrate them. Then hydrate.
What is the reason, sir?
It helps to oppose. You will
Okay.
need less hydration. It will seal more easily. Just try it. I saw Ajit was doing with a soft stick, the same thing. I am a very impatient person, as you can make out from my surgery, that I don't like keep changing instruments here and there. I use same thing for everything.
Thank you, sir.
So,
So after 3 slow trains, it was a super fast local express from Mumbai. So we are kept a super fast train at the end. So to manage the time. So one more to go. Next case will be panoptics. Everybody will be interested in seeing the panoptics. Before he starts, I would request him to say a few words about panoptics lens.
yeah. Okay. They had- I have this, yeah. So the panoptic lens I have been using for last 4 or 5 years now. And I have lot of satisfied patients with panoptic. In the lot, very as compared to the previous trifocal lenses which I have used. There is very little complaints of the glare and the halos. And even night driving, I never asked the patient whether you are comfortable driving at night. But there was a patient of mine who actually said that he was having problems, and then he came back after a month. He told that now my problems are solved. So it takes some time and it does get solved. You get excellent intermediate vision, which is what is most important for the most people. Near vision also you get very good, but if you have to do a lot of reading, like people who read 7-8 hours a day only reading books, I don't recommend multifocal lenses for them, because somehow I see people get eye strain and they are uncomfortable after some time. So such patients are better with reading glasses. So patient selection is of course very important when you do any of these multifocal, trifocal or EDOF lenses. जरा हे- थोडा खाली सरका ना. बस, मान अशी ठेवायला लागेल ना.
This is little softer cataract, grade 1.
शिफ्ट कर राईट आहे. दिस इज द राईट आहे ओनली ना. सेम
Right.
आहे. शिफ्ट करू नका. शिफ्ट करू नका. In a soft cataract, the way you crack and the way you do is different. I will show you one thing which I like doing, especially with the Centurion machine, is go to position zero when I am manipulating. Neither irrigation is there nor aspiration is there. Only my Phaco probe is used like an instrument. That's all. That takes care that there is no turbulence, and accidentally soft pieces, sometimes you aspirate and then you don't get a hold on them. That does not happen if you are on position 0. So I do that routinely, go to 0, even in very hard when I am cracking and all, I go to position 0, where there is no irrigation, no aspiration, and because you are using such tight wounds, incisional leakages are minimum, the chamber remains very stable. So it is like effective IOP is very low that time, and patient comfort is very good.
K1 is 44.39, K2 is 44.76. It's hardly any astigmatism of 0.37 at the rate of 18 degrees, and the IOL power is plus 21 panoptics. Before he starts, I'll introduce you with our new anesthetist. Dr. Rajesh Tagadpalle has joined us. Thank you, Dr. Rajesh Tagadpalle. He is offering his services free of cost. Thanks a lot. See, I had just made one request to Rajesh, and he was so nice that he has made two anesthetics available to us, and he denied any charges for the same. Thank you, Dr. Rajesh. And now Chetan has just left, and Dr. Vishal Kulkarni has joined us. He is there in the OT as a standby and veterinary surgeon. So nice of you, Chetan. Sorry, so nice of you, Vishal. Chetan has just left.
There is a ETO set over there. You can open it. Second set, no, त्याच्यात नाही आहे. I have taken it out and kept it. My name is written, plastic pack है उधर ही है. Yeah, that's sterilized set. ये अभी इंस्ट्रूमेंट सब निकाल रहे हैं. वो दूसरा सेट में से आएगा ना. हे आपण ते लहान बॉक्स मध्ये ठेवलंय.
So this is grade 1. This is going to be the last live case. Dr. Manisha is going to do it. Dr. Ajit Hazari and Dr. Hanuman Bhosle has already left this place for the venue. So they will join you within 10 minutes. And maybe after we finish the live cases, I request Dr. Sujata Joshi to continue the session with Dr. Namita Hazari. We'll be joining you afterwards. Once we come there, we can have regular Deep Prajolan and other things.
Open from the center only. Yeah. उधर से सेंटर में से खुलेगा. पिछला भाई डोळे उघडा जरा डोळे उघडेच ठेवायचे.
The case is being prepared.
घाबरू नका. हा एकदम स्पष्टपणे हा आरामात उघडे डोळ्या करा. उघडे आता हे थोडं थोडं तुम्हाला जाणवत आहे. थोडं जाणवेल. पुढे जास्त जाणवत नाही. चुकणार नाही. घाबरू नका. आता असंच ठेवणार. लाईट येणार समोर. ते लाईटीकडे पाहायचं आहे आपण. पॅराकिन आय ड्रॉप. आता पहा लाईट दिसते ना आपल्याला. ते लाईटला मधलोमध बघा.
Vishnu, are you there? Vishnu?
Yes, you can see the sensation is good.
Yeah, after he finishes, you can start the sessions, PowerPoint presentations with Dr. Namita Azari.
Okay, okay, sir.
We'll be joining you. Once we'll join, then we'll do the clinical sessions.
Okay.
So you will be starting at 12:45 approximately, and 15 minutes each means we can say we can wind off at 2 o'clock. So we'll be on time. We're not too late.
Yes, sir, yes. Sir.
Inauguration session we'll do within 10 minutes.
रंगबिरंगी दिसतंय ना सुशीला भाई? रंग रंग बघत राहत असं ना.
Though it appears whitish, but it is a soft cataract because I have seen the patient on the slit lamp.
It is a soft cataract, but glow is red glow is very poor.
Yeah, that is why it is very important that you, before analyzing the patient, you have to see it on the slit lamp. You never analyze the grade on the microscope.
Correct.
It is always deceptive. A brown cataract will appear like a softer because you will get a good glow, good red glow, but it may be a brown cataract if you get a good red glow. But if you see on the slit lamp, then you will come to know that it is a brown cataract.
So I think I can use Oro Blue in this, but I am thinking of not using it. Ideally, you should use Oro Blue. Yeah.
We
Yes,
have it, sir.
but I am going to skip it. Hmm. For those of you, I started doing Phaco before we had even heard of Oro Blue. And I have used to do MatCat without Oro Blue. How we used to manage that, you can imagine. How I use Oro Blue, it's not that I don't use. But like this case, actually, I don't think y'all have seen anything. But I have done the rescue.
So how much rexes you aim for in such cases of panoptics generally?
Sorry, I couldn't hear.
What size of rexes you prefer, sir, in such
Standard.
cases?
I do the same rexes for every patient. Whichever lens I'm going to put, I don't vary anything.
Okay.
Because see, the size of the lens is exactly the same. It is built on the same as the IQ, na? And even the Clarion, it will be there in my presentation. The Clarion also is designed on the Clarion also is designed on the size and the shape and the physical diameter and all is exactly the same. So one thing which I would like to do different is to stop these air bubbles, they always harass me. Letting go of a little.
ये बड़े सर थे यहाँ पे समझ
So now I am on what I was telling you, position 0. There is no irrigation. Now irrigation starts again. And when you want to rotate it a bit. And in some cases, you don't get easy rotation. So I'm just going to show, I'm without rotating, quadrant mein karo, quadrant. So without rotating much. Again, position 0. In soft cataract, you can do all this. So you got the piece. Okay. Then you can rotate little bit and again hold. In these cases, sometimes I am scared that there may be, though Vivek must have checked, but posterior polar. But I always have a fear. And in posterior polar, I don't rotate.
In posterior polar, you don't?
I don't like rotating too much.
Yeah, that's good.
I am trying to show here how I do the surgery without rotating. So I picked up that piece without much of rotation, as you all observed. I just to show that that is what I do. If there is a posterior polar, I prefer not to rotate too much because you don't know where that thing will be adherent. And by rotating like a screwing action, you are allowing it to open up more easily.
Nicely done, sir. Looking at our your technique, I'm
Perfect.
thinking of planning a full Phaco training session next time with you only.
Well, I started
So-
my career with a lot of Phaco training. When I was junior consultant at Bombay City Eye Institute, we were the first people to start Phaco training in the year 1997, that time. And we didn't teach clear corneal, we used to teach scleral corneal, scleral tunnel Phaco. Yeah.
Means you are the you are amongst the earliest surgeons who have started Phaco. 1997, I think we were there in Mumbai in 2000, and many people were at the starting phase of Phaco,
Yes, very much true.
even in 2000.
And one thing is there, what I would like to take on record to say, Phaco machines have improved a lot. And this machine which I am using, Centurion, I can, even when I have a black cataract the next day, I still sleep very peacefully. So the axis is a little funny, but I don't think that will matter.
I think Alcon people are listening to it, what you are saying about the machine and all that. And if I echo it, they will listen it loudly and, and remember it whenever they come to us. At least they will help.
No, so I was saying that next time you can keep black cataract.
Next time, sir, next time. This was the first time we are
Yeah.
planning, we are doing a live Phaco surgery
Yes.
sessions.
So black cataract also, and up till I had the Centurion, I used to do an extracapsular. Now I do it with Phaco.
There's something about lens you want to tell to the audience, possible?
ये लोड किया है इसमें, इसको डाला नहीं है ना, डालना पड़ेगा. So the lens is just like an IQ lens, as you can see. And the way to put it is also just like an IQ lens. It is the no different. So the injector is also the same way Dr. Ajit used for his toric lens. At some point in time, I think Alcon will bring these lenses on the Clarion platform, which I think is a better platform. So till they do that, we have to use these. So I'm going to inject this lens through the 2.2 incision only. I'm not extending. सुशीलाबाई लाईट कडेच पहा. Injector is a little new, I think. It is. I am used to my old injectors, which are very soft. This one is a little rigid, but it's okay. It's new, new means like that only. It's okay. So that was through a 2.2 incision. I have not extended the incision. And you can see the lens with the ring. Now, important that at the end of surgery, you center that ring properly. Otherwise, I feel that functioning is suboptimal. It doesn't function so well. And washing or aspirating the visco, which is behind the IOL, is also very, very, very important. A lot of patients post-operative IOP spikes are because of retained visco. So whichever you are using, spend a little time to clean it all up. लाईट कडे पहा कुठलं काही झालंय लेन्स पण बसली आहे असं थोडं जरा पाणी टाकून साफ करतोय आणि झालं.
Any questions we can ask there? Just to point out, Panoptix is an excellent lens, but it's very costly. And I personally prefer active trifocals most of the time. And if I use hydrophilic, which I'm using less and less nowadays, I use plate haptic design because there is bound to have some amount of PCO. So if the PCO is going to be there, if you use the plate haptic design, it will be more stable compared to the C-loop active kind of a design. So I personally prefer ID with a plate haptic and acrylic with a C-loop.
So here I am spending little time.
Excellent surgery, sir.
So that the lens is well centered.
So this lens, I guess, has a 15 rings, which kind of focuses for the near also the intermediate 40 to 60, 60 to 80 also.
Very well centered over here now. I can see it. I am satisfied. Thank you.
Yeah, images are bang on the center. Excellent centration. So, thank you. I think nicely done. All the cases went fine and excellent.
आणि ते
I think we'll go ahead with the next part of our CME.
हे नीट सगळं दुसऱ्यामध्ये काढलं आहे ते पण क्लीन करायचं. Okay.
Dr. Vivek, sir, hello.
Done.
If any questions we would like to have now, I think we'll go ahead with the next session. Yeah. And
Thank you very much, Dr. Vishnu Gonsekar and Dr. Nikhil Govindwar. Now we will proceed with the next session of our CME. The CME itself being conducted after a long gap of many months. First, there was a gap of COVID, and then I don't know, there was still another secondary gap.